Hello, students. Good afternoon. Welcome to our live stream of the NEET PG recall. From where we are streaming, there might be some lag of few seconds. So all of you can tell me whether am I audible to all and am I visible to all and is the audio video all clear? And can somebody also tell me, type something in the chat box so that I know the chatbot function is also perfectly working. Uh, so is Yes. So am I visible to all? Am I audible to all? Can all of you hear me? Can all of you see me? And can I also get some messages in the chat box so that I know that the chat box functionality is also working and all of you are able to I can communicate with you through the chat. Yes. Okay. So we will be discussing today. The NEET PG 2024 recall session. These are all the MCQs which I have got from all of you, dear students. Thank you for sending in all the MCQs. And of course, some options may be different. You are always welcome to tell me what was the correct option and what was the exact option which all of you had got it in the actual paper. Okay, there might be some debate, but let's stick to mainly getting the answers. The focus is on learning and getting how much all of you have got it correct. But before that, I would like to thank all of you, and I am so happy that everybody is extremely happy with my lecture series and everybody has really benefited. So many messages and phone calls since yesterday. Thank you messages and appreciation messages. All of you can see this. And I also would want to tell you that yesterday night we had put up a video for the session 1 recall, which has already crossed 10,000 views. So all of you can also go and see the session 1 video also. And now we are going to discuss the session 2 video first. Session 2 video is as a shift 2 MCQs I'll be discussing first, and then at the end I'll also be discussing the shift 1 MCQs also. Okay, so these are all the messages which all of you had sent me. Thank you very much, and I request all of you can download the OGGuru app and get in touch with me on phone and WhatsApp on this number, and I'm there to guide you, and I'm available for your guidance and for all the upcoming examination. Okay, so let us begin our discussion, and do not forget to hit the like on the YouTube button, and also do not forget to follow me on Insta for all the upcoming examination. Okay, and this is the app offer. We are having an independent offer, and depending on your future examination, 3 months, 6 months, 12 months packages are available at an extremely highly discounted price. So definitely subscribe to the app, and definitely first you can get in touch with me. I'll be guiding you how to study, how to prepare. Okay, so now let us begin. I want all the answers in the chat box. Do not worry whether we are right or wrong. I want the answer in the chat box. And chalo, the first MCQ. This is, as I repeat, this is the second shift, or as the students say, the afternoon session we are discussing first. The reason being that already I have put up a video for the morning session. Okay, so anybody in the chat box, can you tell me the answer? Okay. Yes, can anybody tell me the answer? Yes, so our 18-year-old girl has amenorrhea and cervical softening. What is the sign? Anybody, cervical softening kya sign hai? So what was the trick to remember? That sir, during non-pregnant status, the cervix feels like the tip of the nose. Okay, the cervix feels like the tip of the nose, but during pregnancy the cervix becomes soft because of all the hormonal changes, and during pregnancy the cervix will feel like the lips. Okay, will feel like the lips, your lips. So tip of the nose is slightly firm, lips are soft for all of us. Unless you are very unlucky, it will be other way around. Yes, very good Rahul Singh, absolutely correct. So if the lips are soft, yaad kaise rakhna hai? So if the lips are soft, it is good. Yes or no? If your lips are soft, it is good, and that is the Goodell sign. Okay, so Goodell sign is the answer over here, cervical softening. Anybody, what is the Osiander sign? Just by the way, Osiander sign kya hai? It is on PV examination. We feel the pulsations in the lateral fornices. Okay, so I'm just also giving you a couple of more extra information also with this MCQs, and I'm so happy all these questions, those who have attended my lectures have got almost all the MCQs correct. Okay, so Goodell sign is a cervical softening. Very good, better Rahul Singh, and keep on answering. Yes. Now, anybody, this was, I'm really surprised in the topic of breach. We have discussed breach in detail. Breach ke topic pe 3 MCQs came. Okay. Now, what is this image? Anybody? What is this image which is being shown to you? Yes. Anybody? Can anybody tell me what is this image which is being shown to you? Okay, so this is the image of what? So sir, in the initial part of the image, the baby is in breech position and we are rotating the baby and finally making the breech into vertex through the externally. So what is this procedure? पहले खाली identify करेंगे कि ये procedure क्या है. Anybody, what is the name of the procedure? So name of the procedure is external cephalic version. External cephalic version, because externally, through external maneuvers, we are rotating the baby and making the breech baby into vertex. Anybody, why do I do this? Why do I do the external cephalic version? Any idea? So the external cephalic version is done so that I avoid complications of breech. The purpose is what? Okay, we avoid complications of breech delivery. Complications of breech delivery is avoided, and also we can avoid LSCS. Otherwise, for breech, we might have to do LSCS. Very good, Riptara Roy, excellent. This was the external cephalic version. Okay, so now can anybody tell me, the question was all are contraindications except or which is not a contraindication? So obviously, and you all are free to tell me if your answers were different or your options were different, because this is a trick. Okay, so yes, when the membranes have already ruptured, I cannot do active contractions, labor, what else? Okay, twin pregnancy, multiple gestation. In twins we do not do external cephalic version. Okay, severe preeclampsia, hypertension, previous LSCS, also we don't do external cephalic version. And can anybody tell me, please understand this common sense, कि sir, when anyway we are going to rotate the baby. Okay, sir, this is the uterus, this is the placenta, it is a patient of placenta previa. तो बेबी प्लासेंटा फाड़ के बाहर नहीं आएगा. Yes or no? फटा प्लासेंटा, निकला बेबी, निकला हीरो. Not going to happen. So baby cannot perforate through the placenta and come out. You know that. So sir, placenta previa में anyway I am going to do LSCS. So anyway, where all the conditions where LSCS is anyway going to be done. Because why? Because please understand, rotating the baby can have its own set of complication. Okay, there could be cord around the neck, rupture, and baby can die, fetal distress. So ऐसे ही हम time pass के लिए नहीं baby को घुमाते. So where anywhere we are going to do LSCS, automatically the external cephalic version will not be done. Yes or no? Yes, Prathishta Umrao. Okay, sir, placenta previa also becomes a contraindication, and multiparity also, the lady who has already delivered one time, two time, for them breech is not a problem. Primi with breech goes for C-section, and therefore very good, Prathishta Umrao. Primi gravida is the answer to this MCQ. Okay, sir, if it is primi gravida, I will do external cephalic version will be tried. What is the logic? So that, sir, I can avoid LSCS. Is this understood? So in primi gravida and at around 36 weeks time, after 36 weeks, 36 to 37 weeks, the external cephalic version can be tried. Okay, is this understood to all of you? Yes. Can I get 5 thumbs up in the chat box so that I can proceed further? And yes, thank you for all your love and appreciation which we have been getting since yesterday. Do not forget to subscribe to the YouTube channel and quickly share this video with all your friends and tell that Punit sir is live so that you can also enjoy the session. Yes. Now anybody, very simple. Again, ye kya hai? Very yes, we had discussed in our image based sessions also, and this. Okay, so I repeat the answer to this MCQ: PROM, placenta previa, multiparity, twins, all these twins cases, and even hyper, all this, even previous LSCS वगैरह होता है. In this, there's a risk of rupture uterus. So in all this, we do not rotate the baby. We do not rotate the baby. All are the contraindications. And even active labor, my dear students, याद रखेंगे आगे के लिए. Even active labor, when there are already labor, when there are already the patient is in labor, contractions, I would not do ECV. Okay, yes. So what is this image now? What is this image? Yes, this is the Burns-Marshall maneuver. What are we doing? We are very good. Okay, we are holding by the baby by the lower limb, and the baby, so initially the baby is hanging down. The baby is hanging down. What is the dictum? The back should face the doctor. The back should face the doctor. So the baby's head is still inside, and we will hold the baby by the lower limb and rotate it up towards the maternal abdomen, or towards the mother's head side. And this is our Burns-Marshall. Yes or no? I hope all of you got this correct. This is a repeat question. This has been asked previously also in the examination. Yeah, that is okay. And you may want to put a hand near the mouth also, but mainly when you are rotating the baby with this, when we are rotating the baby by the lower limb and rotating upwards onto the maternal abdomen, that is the Burns-Marshall maneuver. Okay, when we are doing the malar flexion and shoulder traction, that is Morrissey smelly wheat. Okay, one more maneuver bonus, MSV maneuver. So in MS we do MS. What is in MS we do? MS का मतलब क्या है? All of you, just by the way, extra information कि sir, in Morrissey smelly wheat is another name, another maneuver. We do MS मतलब sir, I do malar flexion, and along with it we give shoulder traction. Okay, shoulder traction. Okay, that is the MSV maneuver. Okay, now yes, again I am so happy. I had predicted this many years back in the year 2013, 2014. I had said that this is a Virgin MCQ, and right from day one of my lecture we are teaching this image, and this came for the first time ever. Yes, my dear student, this is a Virgin MCQ. Now it is no longer a Virgin. Virgin means it was asked for the first time ever. And anybody, what is this? What is this maneuver, or what is this instrument? So all of us can see that, sir, the breech, all of you can see the legs are out, the breech is out, and the head is inside, head is still inside. So we are delivering the after coming head. Very good. आफ्टर कमिंग हेड का डिलीवरी हो रहा है, एंड ऑल ऑफ अस कैन सी दिस फोर्सेप्स. दिस इज अ स्पेशल फोर्सेप्स called as the Piper's forceps. Okay, the reason, very good, all of you, the reason why we apply this is that it causes the least damage to the baby, and it is very good for fetal safety. The brachial plexus injury is the least. Reason nobody is going to ask you, but just for me to tell you. Okay, so Piper's forceps is the answer over here. I hope this many of you may have got it correct. Yes, next MCQ क्या था? Nugent scoring. Okay, or Nugent scoring. Okay, this is more of a microbiology question where the vagina flora, we stain, we take the smear and we strain, and we are looking for lactobacilli. And if the lactobacilli, that is the good bacteria, that is decreasing, then what it is? There is an increased risk of which infection? Anybody? That if the lactobacilli keeps on decreasing, then there is a risk of development of bacterial vaginosis. Yes, because then the Gardnerella is going to Gardnerella infection will increase. That is because, and that is giving rise to bacterial vaginosis. Okay, so I hope all of you, this is a micro question, but yes, it could be asked also in gynecology also. Okay, all those are joining in now, after the stream is over, you can also go back and see already 3-4 important images we have discussed. Okay, yes, now tell me how many of you cut copy paste from my MVP MCQ discussion. Yes, how many of you agree same MCQ tha, but tell me how many of you have marked IUI and IVF. Okay, question was that, sir, on a infertile patient, when we do a hysterosalpingography, we are getting a bilateral tubal blockage or a bilateral cornual blockage. जो भी दिया था. Yes, anybody? So what it is that, sir, whenever we are doing a HSG, hysterosalpingography, and on that there is a blockage, okay, so what do I do? Anybody, can I directly go and do IUI? Why not IUI? Because, sir, in IUI I put the semen inside the uterus. For IUI to be successful, my fallopian tubes, my means the patient fallopian tubes, should be patent. So patent tubes are required for IUI. And yes, when the tubes are blocked, we are tempted to mark as IVF. But please understand this is on HSG, and the take home message is that HSG is not confirmatory. I have to do the confirmatory procedure. Yes or no? How many of you got this correct? Thumbs up. I do a confirmatory procedure, or the gold standard procedure. I had also discussed in my rapid revision session on the YouTube. Yes or no? So laparoscopically, we put the telescope and we inject the methylene blue dye, which is called as chromoperturbation. Why? Because this is confirmatory. So why? Because please understand this, on HSG, while we are doing the HSG, the tubes may undergo a spasm. Yes or no? Yes, the tubes may undergo a spasm. So HSG is never, HSG is always the initial investigation. HSG is always the initial investigation, but it is not confirmatory. That means whenever there is any problem on HSG, what are we supposed to go and do? Sir, we are supposed to go and do laparoscopy to confirm our findings. Is this understood? And yes, on laparoscopy also, if they tell you that the tubes are blocked, then we can think of IVF. Is this understood? But directly I don't go for IVF. Yes, can I get 5 thumbs up? Is it understood to all of you? So now moving on to the next question. Yes, this was one of the toughest MCQ again from my analysis. Paper 2, yes, was slightly difficult. Luckily that kept the question same. Dono mein max self question was asked, dono mein MTP was asked, both the papers, the topics of they had similar kind of a things like PPH, that questions were asked, but paper 2, according to me, was slightly on the difficult side. Okay, yes, now anybody, what is this? Okay, so here what it is that we have got a episiotomy scar, and after 2 months of delivery, the patient complains of pain and bleeding from the scar tissue, which increases during menses also शायद दिया था. So please understand this, melanoma वगैरह नहीं होता है, inclusion cyst also rare, and retained suture material नहीं. Most of the time we use a absorbable suture material which will get dissolved. Yes, in my video lecture, very rare, we had told us that yes, very good Rahul Singh, this is very rare. Scar endometriosis. Scar endometriosis का मतलब क्या है कि सर in this scar tissue, episiotomy scar, there might be a endometriotic nodule. Which is something like this. And whenever, as all of you know, endometriosis में क्या होता है कि during menses the endometriosis flares up. So during menses, this kind of a scar, this kind of a endometric nodule is going to flare up and cause lot of pain also and bleeding. And I think was it mentioned during menses? Yes, during menses भी mention किया था. during menses there is pain and bleeding from this scar, and therefore yes, it is endometriosis. Agreed. This was a very tough MCQ. Even if you have got this, if you have left it, okay, but if you have got it correct, it is superb. Okay, this is scar endometriosis, and it can occur at which side, sir? Episiotomy scar? Any other scar? Yes, sir. Even LSCS scar, this kind of episiotomy scar, this can happen. Okay, so scar endometriosis, very rare condition. All of you are welcome to put and tell me if the options were slightly different or something, or the stem of the question was different. Please let me know. Okay, and do not forget to hit the like button and share this video with your friends and colleagues. Yes. Now anybody, ye kya tha? Anybody, somebody told me that intra-op picture was given, intra-op finding was given, and what was it? 2 fundus and 2 cervices. Is it yehi tha? Yehi tha, 2 fundus and 2 cervices. So what it is, anybody? What it is, anybody? Yes, yes, yes. So please understand. And how do I differentiate? How do I differentiate between a bicornuate uterus and the uterus diadelphius? Yes, yes, yes. Anybody? How? What is the main difference between a bicornuate uterus and diadelphius? Okay, anybody? So kya tha ye? So please understand this, that bicornuate uterus mein there will be 2 horns, there will be 2 separate horns, but the cervix will be single. Is this understood to all of you? बेटा मिलिन, हाँ, यहाँ पे ऑप्शंस बेटा आप मुझे बता सकते हो डॉक्टर मिलिन सेजल, व्हाट आर द ऑप्शन? बट द ऑप्शंस कुड बी योर bicornuate uterus, bicornuate, unicornuate, septate, and diadelphius. Okay, uterine diadelphius. These were the options. Okay, Dr. Milin? Yes. So anybody? So what it is? Yes, very good. Diadelphius में sir complete duplication. Complete duplication में you will not only see 2 horns, मतलब 2 fundus, but even 2 cervices. Is this understood? So the question was that at the time of delivery, the doctor, we are seeing 2 cervix. Okay, cervix 1, cervix 2. So you can see it's a complete duplication. जब complete duplication होता है, that we call it as diadelphius, and that is the answer. Okay, diadelphius is the answer. Okay, yes. Anybody? Moving on. So that's the differentiation between both of them. Keep in mind, bicornuate means 2 horns will be there, but the cervix will be single. So even on clinical examination, and here 2 horns and 2 cervixes will be seen. Okay, moving on. Yes. Anybody? Perineal tear. Can anybody tell me exactly which was asked, 3rd or 4th degree? So sir, when only the skin is torn, that is the 1st degree perineal tear. When the skin के साथ the muscles are torn, that is 2nd degree perineal tear. When the anal sphincter is also torn, that is 3rd degree. I think most of the students told me sir 4th degree tear was asked, and because even the anal the cut is going onto the rectal mucosa, and even the anus and the rectal mucosa. So when the rectum is also involved, rectal involvement and rectal mucosa, that is the 4th degree perineal tear. Is this understood, all of you? Yes. So just those who are joining in now, also do not forget to see the after the stream is over, the first session, because lots of images. My interpretation was overall yes, 4th degree rectal. Very good, very good, Vanshika Sahu. Thank you for the confirmation that yes, rectal mucosa involvement, perfectly correct. 4th degree perineal tear was the answer. Yes, my overall students told me that almost like 70 to 80 out of 200 MCQs, 70, 80 were images. Yes, in first session also we had 4-5 images, so unusually high number of images. Yes, and all those who yes, thank you for all your love and appreciation. Thank you, dear students. Yes. Okay, now what is this? Anybody? Chalo. So kya hai ye? Sir, uterus ka cut section. Of course, this is my own personal patient. I had done a hysterectomy some last week, last month. So but similar question was given to you. Okay, identify. So here what we are seeing is that within the cavity of the uterus, I'm so happy I had put this image in the Insta also. If you go and check my Insta, I had put this image. Okay, so you can see sir, this is the uterus. This is the uterus, and what is this kind of a circle जो हमने arrow mark करके बताया है आपको? It is within the cavity, and therefore my diagnosis is submucosal fibroid. Yes or no? Submucosal fibroid is the answer. Options were, I think, intramural fibroid or subserosal fibroid, and also I think adenomyosis. But adenomyosis may you need to adenomyosis there would be, yes, whorl-like appearance was shown. Excellent, very good, Vanshika. If whorl-like appearance is shown on cut section, then that becomes further easy. Absolutely correct. All of us know on cut sections fibroid have got a whorled appearance. Excellent. Okay, and I think in adenomyosis, in adenomyosis we get basically within the myometrium. Okay, within the myometrium we get this black dots which are congestion of adenomyosis. So it is not adenomyosis, this is submucosal fibroid, which is the answer over here. Okay, moving on to the next MCQ. Yes, anybody, I hope all of you got this correct, that what do I do? Okay, sir, pregnancy bhi hai, IUCD भी साथ में है, but the threads are visible when I do a per speculum. What is the next step or the next best step to be done? Okay, so remember this, that whenever if the threads are visible, first thing is we will try to remove the IUCD. Why we try to remove the IUCD? Anybody? To decrease the risk of infection, and abortion. Okay, thank you, Dr. MYT. Thank you for your love and appreciation. Good explanation. Yes, beta, you can see all the videos on the YouTube. You will really get very good explanation, and thank you for all the love and appreciation. Yes, so पहला हमारा ये है कि we need to remove the IUCD to decrease the risk of infection and abortion, and therefore yes, remove the IUCD is the answer. Okay, suppose we are not able to remove it, then no problem. If we are, so we will try 1 to 2 attempts. Okay, so 1 to 2 attempts, very good. 1 to 2 attempts should be done to remove the IUCD, and if we are not able to remove the IUCD, then you can keep it inside. Don't worry, nothing will happen. Anybody, if I keep the IUCD in situ, will it cause malformation in the baby? No. Please keep in mind, IUCD which is kept in situ will not cause any malformation in the baby. Next year ये question आएगा, no malformation. It's going to be outside. Okay, क्या होगा? Baby will keep on growing, and कैसे होगा? Baby will deliver, and क्या करेगा? Baby copper T साथ में लेके निकलेगा. Is it? Baby will bring the copper T out and give it to the doctor. No, ऐसा नहीं होता है. The baby will not bring the copper T, but baby will come out. एक WhatsApp पे joke चल रहा था कि baby is born with a palm. Baby का मुट्ठी खोला तो IUCD था. Okay, so that's a fake image, but copper T is always on the outer side. So it will basically copper T will remain there. After the baby comes out, post placenta, the copper T can come out. Yes, but the answer is very good. Remove IUCD, that is the best answer. Yes, okay, and if not, then we can leave it, no problem. Now, anybody, this again a slightly, I would not say tricky MCQ. Lady wants MTP by medical method only. She is, however, 10 weeks. Okay, so all of you know. No beta, other option give progesterone, no point na beta. Ayush, ये करके क्या मत, there's no point giving progesterone. Progesterone is not going to cause any this one. Main thing is to remove. Yeah, but thank you for adding this. Add progesterone was the option. Okay, add progesterone or give progesterone. No, progesterone is not going to be any beneficial over here. Okay. Yes. Okay. Yes. Now, ये क्या है? Now, please understand this. I'm so happy, and student told me कि sir, when I read this MCQ, I felt like saying thoko tali and all that. मैंने बताया था कि all this saline, mannitol, urea, kachra, dustbin, we don't use this. Okay, and similarly for first trimester. However, we are in the first trimester. Actually, remember, my dear students, कि for the 10 weeks pregnancy, what are we going to do when the patient is 10 weeks pregnant? We are actually going to do suction evacuation, या manual vacuum aspiration. Okay, manual vacuum aspiration is done. Very good, Rahul Singh. Okay, the only option, oxytocin will not have enough receptors on the uterus. Oxytocin receptors only come in the third trimester on the uterus more. Mifepristone and misoprostol. Yes, even though this is up to 9 weeks only, but that is the best option because they said that patient at 10 weeks wants MTP by medical method. So perfectly correct, I agree. Mifi-meso is the only option. Sanilnate aa sakta hai, and dinoproston is PGE2 gel. Dinoproston, anybody, is used for induction of labor. So when the uterus is bigger. Okay, so for dinoproston is a PGE2 used for induction of labor. Okay, so all those who have joined in now, just to give a clarification, we are doing the second session recall. All of you can also go and see the first session video I put yesterday night. The first session already crossed 10,000 views, and we are going towards the end, also going to discuss session 1 MCQs very quickly also. Right now session 2 MCQs are going on. Okay, Anshu, 11 weeks था. Yes, I agree with it. I agree with all of you. Not a well-frame MCQ. किसी ने बोला 10 weeks था, किसी ने बोला 11 weeks था. But even in second trimester, if you recollect, even in second trimester, we still use MIFI and meso when the medical method is asked. Yes, technically till 9 weeks only, up to 9 weeks we give MIFI meso. At 10 and 11 weeks, the failure rate is more. The failure rate is more, so we don't prefer doing it, and that's why I told you actually the best answer would have been suction evacuation or MVA, manual vacuum aspiration. Yes, very good, Anwar. So ये medical board है ना. अच्छा, by the way, can anybody just clarify what this in the first session or second session? Because I'm getting confused. This MCQ, was it in the first session or the second session? मतलब morning shift या evening shift? Yes. So the medical board is required when we are going to do MTP beyond 24 weeks. Okay, certain anomalies are there in the baby, and the medical board is appointed, and in that there is a gynecologist, a radiologist, and pediatrician. Acha, this was not in the second paper. Okay, great. So therefore this was, yes, so this was the first in the first session yesterday, because I could get around 18-20. No problem. This is in the first session. Super, thank you. Yes, so lawyer is the answer. Very good. Lawyer is not a part which is in medical board. Lawyer is the answer. All these three are definitely a part of the medical board. This is for specifically for MTP beyond 24 weeks, the opinion when the court tells. Okay, yes. Now anybody, chalo, ye kya hai? Yes, what is the site of tubal ligation, and tubectomy is done at what site? Anybody? So if the options are fimbrial and, okay, cornual and isthmus and ampullary part. Yeah, I think we'll discuss that. Anshu will discuss. Yes, hysterectomy bleeding. Yes, in that case, yes, I'll discuss that question, Anshu. That is life saving. So doctor cannot be held, and obstetric hysterectomy will have to be done. Okay, it's life saving PPH. So hysterectomy can be done. Yes, anybody? What was the site of tubal ligation? What we generally do a tubectomy at what site? Anybody? Yes, sir, isthmus. Okay, isthmus part is the part of isthmus when we are having the fallopian tube like this. Okay, so we are going to ligate it generally 4 cm from the cornual end. Okay, generally 4 cm. Okay, so there is over here the isthmus part and a part of ampullary. Okay, because the reversal is the best. Okay, yes, very good, Anshu. Yes, so the isthmus part is where the tubectomy is done, and it is not in the cornual part. And the reason is why we choose this isthmus part, because in case if I have to do, the reason was also asked, is the result as reversal is the best. Okay, because in the future if I want to do a reversal, then in the isthmus part the reversal is the best. Okay, moving on. Yes, now anyway, I do not know, many students got confused in this. There is a herpes genitalis infection, active herpes infection. We will not try vaginal delivery. Obviously we will not try vaginal delivery because of, okay, so it's very narrow. Okay, fine. Thank you, Anshu. Thank you. Love you. Thank you for your love and appreciation. Do tell all your friends and colleagues and juniors about this app. Yes. So vaginal delivery क्यों नहीं करेंगे, sir? Because baby is having herpes. Mother is having herpes. The baby will get infected the baby will get infected with herpes in the skin, mucosa, everywhere. So to prevent the baby infection, I will go and do LSCS. Please understand this now. Many students told me classical. No, please understand that the infection is in the herpes genital, means on the vagina tract, inside the vagina and inside the labia. So there is no point. Yes, LSCS is the best. There is no need to do a classical. Many students thought, and it's previous to LSCS, so vaginal delivery is definitely not, we are not going to allow vaginal delivery, so we will do a repeat. Okay, if it is previous to also, some student had a doubt yesterday, even if my dear student it is previous 2, previous 3, previous 4, again we can do a repeat LSCS only. Classical is not done. Classical, rarest of the rare cases. Classical, if there is a large lower segment fibroid or cervical cancer, I've discussed in my videos the indications for classical. Okay, so very good. Repeat LSCS will be done, and you don't have to worry because अपना LSCS यहाँ पे है, infection तो बाहर के side पे है. Yes, very good, Anshu and Karthik and Rahul, all of you. Okay, so till now, no beta, we will not try. Anshu, we will not try vaginal delivery. Yes, that's what I told you. So this will be called, okay, ये जो vaginal delivery हमने लिखा ना, very good. Anshu, thank you. This vaginal delivery is same as TOLAC, trial of labor after cesarean. Again, in previous 2, trial very dangerous, and I don't want to give a trial. Why? Because the baby will get infected. समझ में आ गया? So I don't want to give a trial because I want to prevent the baby infection. Okay, so since I want to prevent the fetal infection, fetal or the newborn infection in the newborn, I want to prevent the infection of herpes, we will go for LSCS only, and VD, vaginal delivery, we will not try. Yes, very good. Thank you, Anshu. Yes, correct. Yes. Now, MGSO for toxicity, again so happy. Maxal toxicity दोनों पेपर में आया, okay? So smart. Paper 1 also देगा maxal toxicity, paper 2 also. Yes. So maxal toxicity, all of you, which is not routinely monitored. Okay. What is not routinely monitored? Anybody? So what are the things which we do? Urine output, चलो कितना होना चाहिए? Respiratory rate, of course I monitor. Knee jerks should be present. Knee jerk should be present, and urine output should be at least 25 to 30 cc per hour. And based on this knowledge, हमारा morning session का भी MCQ is getting solved, because there was that when you stop maxal 60 cc per hour. Yes, so your serum magnesium levels we don't routinely monitor. No, all patients we don't do serum magnesium level. That is the answer. Okay. So maxal toxicity had also kept in my prediction reel that all of you do maxal very well, and so happy. So yes, knee jerks, urine output, and respiratory rate, all are monitored. Moving on, yes. So before I proceed, all of you, just a quick thing that this is the best chance to get in your app. It's a super discount, and all those who are giving the upcoming exams, the INI-CD and all that, can get the November INI-CD 3 months and next year exams can quickly get. And freedom is this. Freedom is the code to get the maximum discount. Yes, 30 cc per hour in the option. Very good. Yes, it should be at least 30 cc per hour. Thank you, Anshu. Okay, so quickly all of you can download the app and take your subscription as per your requirement. And any doubts, you can get in touch with me on this number. I will guide you how to prepare, how to study. Okay, so these were all the questions. Now before we go, anything left in the, I think still now I will be going with the morning session, but before that there was some, I think, any questions left in the afternoon, in the evening session. Okay, this is what I had got. Anybody? So this is quickly maxillary toxicity not routinely monitored, and this. Okay, so anybody, any other question left? I think one question which was left in the evening session was that after few months of delivery, there is some mass coming out. Okay, some mass coming out, or a query, some mass is coming out for per vaginal examination, that I feel is not a placental polyp. A placental polyp will remain only inside. Okay, placental polyp agar hoga na, it will just remain inside. Okay, so it is your it could be the inversion of the chronic inversion of the uterus. it could be there, inversion of the uterus. Okay, and one of the condition which also one MCQ which have not got all the option, there was a question of prolapse uterus also. Okay, so these are all almost 20 questions were there in each of the session. Okay, so anybody prolapse uterus mein, yeah, 2 more questions were there. Yeah, implantation question kya tha, Dr. Mani, if you can tell me. Yes, in a prolapse uterus what was asked was, I'll tell you one more thing. In the prolapse uterus mein, it was a young patient of prolapse, young patient, and please understand that in young patient with cervical elongation, para 2 leaving 2, family was complete. Yes, so please understand that normally I avoid doing Fothergill surgery, and what is our dictum? Sing is king or sling is king. So in a young patient of prolapse, actually we prefer sling surgery, but that was not in the option. So for that MCQ, I feel the only option is Fothergill. Okay, Fothergill. Yeah, implantation beta happens on the 6th day following fertilization. Okay, so implantation was on the 6th day because on the 4 days it take to travel. 5th day or the 6th day is what we can mark. 5th or the 6th day. 6th day is the best to mark for implantation. Okay, and one very difficult. Okay, so यहाँ पे क्या options था? You know, young prolapse का patient में, young patient of prolapse. Young patient of prolapse. So one was your, of course, hysterectomy. If we do hysterectomy, we'll have to go to jail. Okay, okay, so hysterectomy nahi karenge. And yes, this is the only time, and I think one was also Mackel's scaldoplasty. Scaldoplasty is done for prevention of enterocele, so that is again not the done. And sacrocolpopexy bhi nahi tha. So here it is only thing that unfortunately Fothergill is not done, but Fothergill is the answer over here because the family is complete, because the patient was para 2 leaving 2. Okay, and last, if I remember, one question was sacrocol, very difficult MCQ, sacrocolpopexy. ये भी था. In sacrocolpopexy, where is the mesh attached? Was this the MCQ in the paper? Anybody quickly? So sacrocolpopexy is a surgery for what? Okay, so sacrocolpopexy, remember my student, it is a very rare surgery for vault prolapse. Vault prolapse. Okay, so again a difficult topic, again a virgin MCQ, but I'm happy I have discussed it in my video lectures. So many years after hysterectomy, the vault, we close the vault. Okay, so vault is the top. Yes, very good. So vault prolapse is happening, as the name suggests, sacrocolpo. तो क्या करते हैं? Mesh. Okay, so this is the sacrum, and the mesh is taken, and the mesh is anchored between the, yes, sacral promontory, SP लिखेंगे, sacral promontory, and then to the other part is attached to the vault. Very good. So sacral promontory is the answer to this very difficult MCQ. Unfortunately, yes, it was very difficult, but the answer is sacral promontory. So in vault suspension, vault prolapse, sacrocolpopexy. Okay, so these were all the images. One more image was there, but that was more of a radiology MCQ, where they had given you a mass of a chocolate cyst and pain during menses, dysmenorrhea history was given to you, and they had said MRI features, and that is a endometrioma or a chocolate cyst. Okay, so these were all our sessions. In the afternoon or the evening session, I discussed that first, and now we are going to discuss all the MCQs of the morning session also. If anything is left out in the evening session, I've discussed the evening session MCQs first. Okay, anybody, all of you are welcome to put in the chat box, and do also in the comment how overall was your exam, and like the video if you have benefited from my video sessions. Okay, now morning, anybody, this is what अपना classical DID, patient is having infertility, dysmenorrhea, dyspareunia. तो ये क्या है? DID. What is your diagnosis? Anybody? The diagnosis is endometriosis. और ये क्या है endometriosis में? This is not a white vanilla ice cream, and this is not the chocolate sauce coming out of it. Yes, this is the chocolate cyst. Very good. Chocolate cyst, also called as endometrioma. Okay, chocolate cyst or a endometrioma. Perfectly correct, Riptara Roy. Excellent, all of you. Okay, so DID. Yes, some student told me, sir, moment I read DID, I remembered you when I said Thoko Tali. Okay, yes, so DID, Dance India Dance, is the mnemonic for all the upcoming exams. Yes, now over here, somebody told me, sir, 36 weeks tha. Somebody told me 37 weeks tha. Does not matter. Okay, whether it was 36 weeks or 37 weeks, all of you know that when the patient is having a prosthetic valve and patient is reaching 37 weeks, what do we do? I do not continue warfarin. Why? I do not continue warfarin. Why? Because, sir, while delivery, and there's no need to do induction of labor. Okay, one of the MC option was also induction of labor. Yes, anybody? That was also in the option. In heart disease patient, there is no need to induce labor if she has reached 37 weeks. Induction when we do, when suppose mother is having severe preeclampsia, all that. So in induction of labor we don't do. We always prefer, because prosthetic valves, matlab heart disease patient. So we prefer in a heart disease patient, we prefer that they spontaneously they go in labor is the best. Okay, spontaneous labor is the best. Yes or no, my dear students? So what is the answer? Yes, sir, we start the low molecular weight heparin is started. Okay, so stop warfarin. And anybody, why stop warfarin? Stop warfarin and start heparin. The reason is why? Because while delivery, because heparin does not cross the placenta, warfarin crosses the placenta. So while delivery, yeah, great. So some students says yes, great. So yeah, overall, always they try to balance the paper. Thank you for your this comment. Yes. So stop warfarin. Why? Because if the warfarin crosses the placenta, when the baby while passing through the birth canal can have internal bleeding and bruising. Okay, can have bleeding and bruising. So the dictum, all of you know that when the patient is not pregnant, chalo kya denge, then the patient will be given warfarin. Okay, if the patient is not pregnant, I will give her, because warfarin is better. Warfarin is a superior anticoagulant compared to heparin. As soon as the patient conceives, as soon as I know she is pregnant, till 12 weeks of gestation, what is given? Yes, sir, till 12 weeks of gestation. Now I give heparin. Anybody, why? Why cannot I give warfarin in the first trimester? Anybody in the chat box? Why should I not give the warfarin in the first trimester? Conradi syndrome. Conradi syndrome. And therefore in the first trimester, that is the complication with warfarin, the baby can have central nervous system and cartilage problem. After 12 weeks are over, from 13 weeks to 36 weeks, yes, the patient can be on warfarin because warfarin is better. And after 36 weeks till the delivery, the patient will be on heparin, which is the answer over here. And after delivery with breastfeeding, there is no problem. Patient can again go back to warfarin. Okay, is this understood to all of you? So post delivery, I'm writing BF with breastfeeding. Okay, so it is exactly, clap if you feel happy, it is exactly alternate W H W H W. Okay, so that is the answer over here. Okay, sir, switch to heparin and stop warfarin. Okay, moving on to the next MCQ. Very simple. I'm sure all of you must have got it correct. Bronchial asthma. Which is the drug we avoid? PGF2 alpha. PGF2 alpha will be avoided because it is a Bronchoconstrictor, yes or no, it can cause bronchospasm, so carboprost will be avoided. Oxytocin can be given, methergine can be given, misoprostol is PG even, no problem, can be given. Anybody? One more MCQ which can come in the future exams. What is the problem with methergine? Methergine is contraindicated in which patient? So for methergine, remember the absolute contraindication is heart disease. Okay, my dear student, heart disease if they tell you, or if they tell you hypertensive disorders. Yes, clap if you are enjoying and if you are happy. Okay, yes. So hypertensive disorders, we are going to avoid methergine or methyl ergometrin. Okay, moving on. Yes, chalo ye bata lo. Primary amenorrhea, short stature, and again some few features were given. Primary amenorrhea, short stature, few features were they given, and what is the karyotype was asked. Clearly we can see only one X and there is nothing over here, so this is 45XO. This is the Turner's syndrome. Yes, even if the karyotyping was not given, all of you we know the answer. Okay, Turner's syndrome. Okay, because and I think shield shaped chest was also given. Okay, moving on to the next MCQ. Yes, anybody in the first trimester with hyperthyroidism, what do we give? Propyl thiouracil. Anybody? Why will I not give methimazole and carbimazole? Methimazole and carbimazole are to be avoided. Why? Because they are going to cause cutis aplasia. Okay, they are going to cause cutis aplasia in the baby. CA. Okay, cutis aplasia in the baby. At few places absence of skin development. It's a pharmacology MCQ. Okay, now again I hope all of you have got this correct. Okay, cervical cancer, I told you in my lecture, this is the only stage which you should mug up. And cervical cancer, what will happen? Cervical cancer, there will be, it will spread to the lateral pelvic wall and engulf the ureter, giving rise to hydroureter, hydronephrosis, non-functioning kidney. This is stage 3B. Stage 3B. Thank you, Priya, for your love and appreciation. Please tell all your friends and juniors about this app. Yes, thank you very much. And yes, okay, so 3B, and do not forget to hit the like button and share this video with your friends and colleagues. Okay, so 3B is the answer over here. Please by at this stage, this is a mug up thing. All of you need to know the staging of the cancer. Okay, now here again, sexually assault victim at 22 weeks. Very simple. We had discussed this, that sir, the MTP law has been changed, and from 20 weeks we are allowing up to 24 weeks, specifically for 2-3 conditions. Which 2-3 conditions we are going to do this? Yes, sir. For fetal anomaly, and specifically for rape victim or sexual assault victim and rape, this can be done. So MTP can be done, MTP should be done is the answer. Is this understood? Clap if you are happy. Thoko tali. MTP cannot be done, ye nahi hai. But yes, whenever we cross 20 weeks, opinion of 2 doctors. Okay, when we cross 20 weeks, 2 doctor opinion has to be taken. Opinion of 2 doctors. Okay, is this understood to all of you? Can anybody tell me this rule change? The rule change is for which option? 20 to 24 is for fetal anomalies, sexual assault victim. Which condition? Still only till 20 weeks we do MTP. Which condition? Mother's life is at danger, definitely I can do at any weeks. Okay, even at 20 to 23. But which condition, if it was there, that I can still do only till 20 weeks? Yes, sir. Failure. This was asked in the last time FMGE exam. Failure of contra. I'm so happy I teach. Okay, sir, if it's a failure of contraception, the condom has torn, condom fat gaya hai, don't stay home till 24 weeks. Okay, so failure of contraception, Yes, inversion of the uterus. Yes, Sujit, we discussed that. Okay, there was a patient, something coming out after delivery after 2 months. That is probably from what the options I have got. Inversion of the uterus is the answer. Chronic inversion, because placental polyp and vaginal polyp will not come out. Placental polyp will be inside only. So yes, inversion was there. You can just go back and check. I just discussed that. So failure of contraception is still up to 20 weeks only. Okay, still up to 20 weeks. Okay, I hope all of you have got this correct. Postpartum IUCD insertion, PPIUCD. Government is promoting this. Why? Because if you give the patient home, if you send the patient home back, they are coming back pregnant only. So within 48 hours, while I am suturing the episiotomy or on the OT table at the time of LSCS, within, because the question is how earliest, within 48 hours, this is the postpartum PPIUCD. Okay, and then if we miss the window, then after 6 weeks. Okay, after 6 weeks is again the best time, because the uterus comes back to the normal size. But the question was how earliest time. So within 48 hours. Okay, yes, this part was not shown. Obviously, this was again a tough MCQ in the morning session. One of the tough MCQs, this grid staging, like this grids were given to all of you, and this is, but I'm very happy in my lectures I've discussed this POPQ, as the name suggests, POPQ classification. What is the full form? Pelvic organ prolapse quantification. What were the options for this? Anybody, if can they tell me? Answer is prolapse. Answer is prolapse. Okay, answer is prolapse. Okay, yes. So now, so POPQ classification, this is for prolapse uterus, this kind of classification. Okay, yes. Now there was again a condition told that phase to pubis delivery, 4 types of pelvis pictures were shown, and phase to pubis delivery we get with what? Yeah, MTP of course can be MTP done to, if continuation failed. Yes, definitely easy medicine that MTP has to be done. Yes. Okay. Yeah. Well. Okay. So very good. Well. Okay. So android pelvis is a heart-shaped pelvis like a male pelvis. In that. Okay. Thank you, Mon. Vulval cancer, cervical. Okay. So POPQ classification, POPQ classification options आपके थे CA cervix, CA vulva, and prolapse uterus. Okay. Okay. Answer is prolapse. Okay, yes, and the platypaloid pelvis gives rise to face presentation, and anthropoid pelvis, which is the anterior posterior oval, that is suitable for a face to pubis delivery. Face to pubis delivery matlab this is the pubic symphysis. Baby's face in the occiput is at 6 o'clock. The baby's face faces the pubic symphysis. Okay, so you can see over where the baby's head is coming out, it is vertex, and it is occipito-posterior, and the occiput is posterior. So we see this face to pubis delivery and the occiput is posterior. Okay, so I hope this was a simple thing, all of you. One more I think was there, where an image, I think one of the MCQ, again you can tell me whether it was morning session or evening session, USG was shown and frog eyes were shown, frog eyes and anencephaly. So anencephaly. So overall, the my judgment is that yes, obs gynae was anyway a major subject. 20 to 25 MCQs, and I think all the sessions, both sessions have got around 20 to 22 MCQs in OBGY. So it's one of the very high representation along with medicine, surgery. OBGY is like the top most subject, and all of you have to do it because it's combination of two, gynac and obs. Two subjects are there, so 10 questions from each of them is expected. Okay, so frog eye, and yes, this was in which session? Anybody can tell me? Was there the question? Frog eye was there or not? Yes. Okay, so anencephaly में था ये. And moving on, yes, this was again a difficult Virgin MCQ, but I'm so happy I had discussed it. Where do I place the vacuum cup? Vacuum cup is placed where? Okay, so please pay attention, all of you. The vacuum cup is a circle, correct? Vacuum cup is a circle, and a circle will always have a center. So कैसे आपको याद रखना है कि sir, this is the baby head, this is the fetal head. Okay, this is the fetal head. Here I have very good, encephaly, thank you. Yes, so this is the fetal head, and this is the posterior fontanelle, this is the anterior fontanelle. First shift. Okay, great. This is the anterior fontanelle. Anybody? Where do I place the vacuum cup? The line joining the two is called the sagittal suture. Line joining the two is called sagittal suture, and I will place the vacuum cup as close to the posterior fontanelle as possible. And why? So that the center of the cup is on the pivot point or the flexion point. I'm so happy. I had also said this many years back. There's a Virgin MCQ. I taught it in my lectures, and this is a futuristic MCQ, and it came. Okay, and where is this? So from the posterior fontanelle, we come ahead by 3 centimeters. Okay, so the center of the cup should be 3 centimeter anterior to the posterior fontanelle, which is the answer. That is the, and it should be 6 centimeters behind. So from anterior fontanelle, yes, very good. Vidit Pandey, absolutely correct है. तोड़ दिया है, ठोक दिया है. And from the anterior fontanelle, we can go behind by 6 centimeters. Okay, so very difficult MCQ, but yes, they had asked. Unfortunately, this was the tough. This was simple. Okay, anybody? Chalo. Two images were shown to you, and in which we will go for vaginal delivery, which I will go for cesarean section. So here, when both the babies are vertex, the first baby is also vertex and the second baby is also vertex, we will try a vaginal delivery in twins. Yes or no? Beta Neil Jadhav, we don't do at the ampullary part. Okay, only a part of the ampulla is cut. It is more of the isthmus. Okay, Neil Jadhav, isthmus pe just go back and discuss. I discussed the MCQ. Okay, you can, after the stream is over, you can go back and check the video. Okay. We do it at the isthmus, only the part of the ampulla is cut. Mainly it's at the isthmic region. Okay, yes, and when the first baby is non-vertex, so some students told me, sir, first baby was in breech. Okay, I have drawn the legs down. Or first baby was transverse. Anybody? First baby was breech or first baby was transverse? Okay, so when the first baby is non-vertex, our decision is done and we are going to do LSCS only. Okay, is this understood to all of you? So let the first baby be breech or let the first baby be transverse lie. Second, whatever it is, first baby non-vertex, go for LSCS. Very good. First baby breech, LSCS both is superb. Thank you. Okay. Yes. Now this is slightly, now some, this slight confusion whether prolapse uterus to tha. Yes, cystocele was also there along with it. Cystocele was definitely there. 2-3 students told me. Yes. But fundus was outside or fundus was not outside, and some told me, sir, 4th degree was not in the option and 3rd degree was there in the option and 3rd degree was the highest. So then that becomes the answer, because remember students, what it is that when the cervix is inside, okay, so this is the uterus, this is the cervix. Yeah, this is in session, this is morning session, beta Nilja, the morning session. Okay, and this is the vagina, and this is the vaginal opening or the introitus. This is the vaginal opening or the introitus. Okay, so what we are supposed to check is if the cervix is anywhere over here, that is 1st degree. Cervix is still inside the vagina. When the cervix is at the level of introitus, that is 2nd degree. Cervix coming out, that is 3rd degree. So then this was the answer. 3rd degree was seen. Okay, Vidit Pandey, absolutely. लेकिन 3rd degree में आपको क्या याद रखना है? At the fundus, Okay, I'll draw the fundus in another color so that there is no confusion. The fundus should still be inside. Okay, the fundus, as you can see the green part in third degree, the fundus is still inside the introitus. Okay, fourth degree. Okay, no beta नील ज्यादा वो rectal mucosa fourth degree, that's a perineal tear. Correct नील, you have just joined in late I think. वो correct है, perineal tear है. That was the previous perineal tear MCQ. Okay, students are getting confused. Okay, yes, and the fourth degree is when the fundus is also outside. So if the fundus is also outside, then we have to mark it as prosidentia or fourth degree prolapse. Okay, is this understood? So in fourth degree prolapse, even the fundus is outside. So can anybody tell me whether fundus was given inside or fundus was given outside? Okay, cystocele was there, somebody told me, and somebody told me no sir, third degree was the highest. So I am giving both the answers. If यहाँ पे you can see the green part, this is third degree. Why I am saying third degree? Because why? And if this is the situation where the fundus is over here, fundus is over here, okay, then the fundus is outside, that is the fourth degree or the prosidentia. Okay, moving on. Anybody? Yes, so please understand this, that over here when the placenta is not getting detached, okay, placenta, yesterday night also in the session I've discussed it, previous LSCS specifically, and bleeding not getting under control, this is the placenta accreta syndrome. Again a very difficult. Okay, placenta accreta. What is this? Is that sir, as the remember students, as the combination of previous LSCS, whenever I have previous LSCS with placenta previa, it is a very dangerous combination. Why? Because sir, as the number of LSCS increase, previous 1, previous 2, previous 3, previous 4, as the number of LSCS increase with placenta previa, we are going to get a condition called as placenta accreta. Placenta accreta means placenta is adherent to the myometrium. Placenta gets attached to the myometrium, and sometimes the placenta can even invade into the myometrium, जिसको बोलते हैं placenta increta, and placenta can even grow out. So accreta, increta, percreta. Okay, so that is the placenta accreta, and that leads to definitely hysterectomy because it is uncontrolled PPH. Okay, so I hope all of you must have got this correct. Okay, now there were again the questions over here in session 1. Magnesium sulfate toxicity question was there. Here deep tendon reflex was clearly said present, and urine output was given 60 cc in 4 hours. The question is that when will we see magnesium sulfate toxicity? And that is the answer. Yes, because what I told you, okay sir, the urine output should be at least 25 to 30 cc per hour, and therefore when I give magnesium sulfate 4 hours apart, in 4 hours there should be at least 100 ml. 4 hours में at least 100 ml should be the urine output. Yes or no? Clap if you are feeling happy. Clap if you have gained a lot of knowledge through our lectures. Okay, now yes, here clearly the student had told me that sir, the imperforate hymen picture was shown to you. Imperforate hymen, amenorrhea patient, normal breast, normal development of pubic hair. The karyotype was asked, and in fact normal uterus, normal ovary. Okay, and imperforate hymen picture, was it shown? Imperforate hymen was shown to you? Yes, and the karyotype becomes 46XX. Yes, less than 100 ml in 4 hours, 60 cc दिया था, so that is the answer. Okay, 60 cc urine output was given, so that is the answer over here. Okay. Yes, very good one. So 46XX was the karyotype. Anybody, if I tell you, okay, if I tell you it is primary amenorrhea plus absent uterus then, and if I tell you okay, axillary and pubic hair is absent, axillary and pubic hair, anybody? If they tell you axillary and pubic hair is absent, then it becomes androgen insensitivity syndrome, and then it is 46XY, 46XY. Okay, this was clearly 46XX. And the last MCQ, which was again, some students have told me कि yes ये था E plus P withdrawal negative. Anybody ये क्या है? Anybody E plus P withdrawal negative क्या है? So please understand this, that sir, initially I give progesterone to the patient. Progesterone challenge test. Okay, progesterone challenge test is done, and we give progesterone to the patient, and patient will get the menses or patient will not get the menses. Anybody, if the progesterone देने के बाद patient got menses, what is our conclusion? What is our diagnosis? Anybody? Yes, very important. Okay, sir, progesterone acts only on estrogen primed endometrium, and therefore estrogen is present, progesterone is absent. And which is that condition? Because progesterone acts only on estrogen primed endometrium. So when I give progesterone, there is withdrawal bleeding. So that means estrogen was present. Yes or no? Estrogen was present. And this condition is an ovulation or PCOS. Is this understood to all of you? An ovulation or PCOS. Okay. Now when there is no menses, I have to give double challenge, which is estrogen plus progesterone, and if that is also negative, if estrogen plus progesterone is also negative, that means it is a case of end organ failure, because sir, estrogen progesterone is not responding, the uterus, the endometrium is not responding to estrogen progesterone. That means it is double challenge negative, that is end organ failure. Or another name for another example for that is Asherman's syndrome. But end organ failure means uterus के अंदर so much fibrosis. Okay, uterus के अंदर there is so much fibrosis, adhesions, that it is not responding to E plus P. The end product cannot work, end organ failure. But my dear students, they told me, yes sir, Asherman to was not in the option only. Asherman was not in the option. Is it? Asherman syndrome was not in the option, but what was in the option? Tuberculosis. Yes or no? Thumbs up. And yes, tuberculosis can lead to Asherman. Asherman is because of excessive curettage, but even your tuberculosis can cause Asherman's syndrome, and therefore I will mark genital tuberculosis. To support the diagnosis, I think some students told me, okay sir, the tubes was dilated and tubercles picture. Yes, was an image given to this along with this? Was an image given where there was tubercles on the surface of the tubes? Yes, great. White color tubercles the beta Vidit Pandey, on the tube were the white color tubercles, then that is your genital tuberculosis. So absolutely there is nothing to confusion that E plus P negative, and yes, in genital TB also, genital TB would lead to Asherman syndrome, and Asherman syndrome genital TB hoga, and that is with white spots or the tubercles. Okay, so that is all our MCQs which we have discussed, and I hope all of you had a great time. And the last thing, all of you, please download the OGGuru app, get in touch with me, and for the next 4, 5, 7 days we're having a special offer. Freedom is the promo code, and all those who are preparing for the upcoming examinations, whether it's the NEET PG next year or the your IUCD upcoming 3 months, 6 months and 12 months packages are available at an extremely discounted price, and here you get everything. We are giving you detailed theory lecture rapid revision MVP MCQ, which is a big hit among all the students, and also beautiful notes are available to read in app. Okay, so all of you can download the app, get in touch with me. I'm personally guiding the students. Hopefully the next year NEET PG will not be so much delayed, and if the exam is in March and May is your NICT, 12 months package is the best for you, which all of you can go through. And thank you very much, dear students, for your love and appreciation. Do follow me on Insta, and do also share this video with all your friends and colleagues. And this was a complete recall of both the first session and the second session. I hope I've tried my best. Still, if there's any confusion, any doubts, any one or two chota mota kuch questions have been left behind, all of you are welcome to put it in the chat box. I'll try to answer it. Okay. And yesterday night we had put in a video where the first session recall was discussed in detail, and today in this live stream we discussed both first and easy medicine first session definitely 20 plus. Okay, first session there was definitely 20 plus because we had got till 18-19, and then today morning 1 or 2 we got, so 21 MCQs. That's why I told you OBGY has got the maximum. I'm so happy that OBGY was anyway very high, and it was like the #1 subject, and all my students have got really good marks or will get almost all correct in OBGY is my guarantee. Both sessions, yes, both sessions. And unusually high number of images were asked, which is thoda sa ye images were pretty straightforward, but thoda sa so many images shouldn't have been asked. 1-2 image in each session is okay, 1 or 2 images okay, but I think 4-4, 5-5 images were there in both the session. Personally, session 2 slightly, see, even session 1 also the questions were tough, because session 1 we had the flexion point or the pivot point, this double challenge negative genital TB. Actually, it was a very balanced paper, but because in evening section, the scar endometriosis MCQ came, scar endometriosis, which is like a very difficult PG level, and scar endometriosis and couple of other things. I found the paper to slightly probably 5% difficult more, but overall they had tried to maintain the balance. And even paper 1 had equally tough questions. Paper 2, yes, was on the slightly in the difficult side compared to paper 1, but overall all my students have done very well, and all of you will also do very well when you prepare from me. Okay, so bye bye, best of luck, thank you very much. Do share this video with all your friends and colleagues, and do subscribe to me on the YouTube channel also. Wishing you all the best for all the upcoming examinations. Bye bye, best of luck, thank you very much.